Welcome to the IWH Speaker Series. This is our first presentation of the 2025 year. So we're very excited to welcome Dr. Kathleen Dobson as our presenter today. Before I introduce her, just will take a couple of moments to cover some housekeeping. If you would like to have the closed captioning, you'll find that often at the bottom of your screen under the More button, and you can activate the the closed captioning if you would like that. Because we often get a lot of questions, and there are a lot of people here today who've joined us, which is terrific. We're going to use the Q&A box and ask you to type your question in. So we won't be using the chat for comments or questions. Please use the question and answer box at the bottom of the screen. We do encourage you to ask questions about the study. And if there are so many questions that I can't get through all of them today in our time, we also ask you to please feel free to reach out and contact Kathleen. She will provide her email on her final slide, and you can ask her the questions or have a conversation with her. Because we sometimes get a lot of similar questions, I will bundle them so that I kind of ask similar questions. So it may not be in exactly the words that you have written. And we will hold all the questions until the end of the presentation. So I'll do a little bit of a reminder about this as we move forward when Kathleen is finished. But let me now introduce you to her and let her tell you about what her study's about. So Dr. Kathleen Dobson is an associate scientist at the Institute for Work and Health. She's also an assistant professor at the Dalla Lana School of Public Health at the University of Toronto. She has a PhD in epidemiology from U of T and a Master's of Science in Health Research Methodology from McMaster University. Her research aims to understand how Canadians who experience mental illness and mental health challenges participate in the labor force. Her research also explores the long-term health and employment experiences of injured workers. And today, I'm just going to talk about this in a study titled The Mental Health of Injured Workers with a Physically Disabling Injury. Over to you, Kathleen. Welcome.
Wonderful. Thank you so much, Monique. And thank you to everybody on the call today for taking the time to come out and listen to me describe a study that I think is really important, and I hope that you find it important as well. So today we're going to be talking about a study that was recently published in the Journal of Occupational Rehabilitation. About now, you should see a link to it in the chat. It's open access, which means everybody has opportunity to read it. I didn't do this study all on my own. I had a phenomenal team behind me, my analyst Yu-Chen Chen, collaborators Cameron, Nancy, Andrea, and Peter Smith. And the study was possible due to funding from the Ontario Workplace Safety and Insurance Board. So I'm going to throw a lot of information at you today, but the three takeaways I want you to have are: one, how we define mental health is important. Secondly, the mental health of injured workers isn't a one-size-fits-all. And three, there's an association between return to work outcomes of injured workers and their mental health profile, or what their mental health looks like. So if you're on the call today, I'm going to assume you think one of three things is important: health, work, or a combination of the two of them. And one of the biggest health issues that we talk about as employees, employers, organizations, and as a labor force is mental health. These 6 headlines on your screen are news articles that I pulled from Google News last week when I was preparing this presentation. All of them are talking about mental health. Now, as a researcher in this area, what I ask myself when I see these types of headlines is, what is mental health? And are we all talking about it in the same way? So the definition that I like to use is the World Health Organization definition of mental health. It's more than just the absence of mental disorders. It's a state of mental well-being that enables people to cope with the stresses of life, realizes their abilities, and contribute to their community. This is a beautiful, beautiful definition, but it raises the question, how do we actually measure this in work and health research? The way that I like to measure it and think about it is with a framework called the Complete Mental Health Model. It's sometimes also referred to as the dual continuum model of mental health because it's comprised of 2 continuums that are related but not quite the same. So the first continuum we think about as positive mental health. And this is a dynamic state of emotional, psychological, and social well-being, which enables individuals to have satisfaction with their life, feel a sense of agency and purpose, and really can cope with life's everyday ups and downs. So given it's a continuum, when people have really great positive mental health, we say that they're flourishing. When they're on the other end of the spectrum and not doing well, we say that people are languishing. So moving to the second continuum of complete mental health, we have mental illness and mental illness symptoms. So according to the American Psychiatric Association, and just so we all get on the same page, a mental illness is a health condition that involves changes in emotion, thinking, and behavior. And we know that people that experience mental health conditions typically have significant distress and disability in social, occupation, or other important activities when their symptoms are exacerbated or high. So on this continuum, when people are doing well, they don't have any mental illness symptoms. But on the other end of the continuum, people can have not only multiple symptoms, but quite severe symptoms. So I've spent a couple minutes talking about a diagram with 2 lines. I think it's important, but why should you? Well, going back to our World Health Organization definition of mental health, not everybody experiences mental health in the same way. The reason that I really like this framework is because it doesn't group everybody into the same bucket. Some people might be experiencing mental health symptoms, but they might also have flourishing positive mental health. Alternatively, someone might not have a mental health condition, but they might be languishing and need some help. So given this, I think it's a really great way to think about mental health and think about where we can place our resources to help different people. I'd now like to shift to talk a little bit about why we should focus on the complete mental health of injured workers. So for people on the call that might be a little less familiar about injured workers in Canada, I'd like to just throw out a few statistics. In 2022, there were just under 40,000 work-related injuries that were reported in Canada. And experiencing mental health challenges is common among injured workers. The prevalence of severe psychological distress 1 to 2 years after work-related injury has been reported to be as high as 17%. Now, you might be wondering, why is this common? Well, it can greatly impact somebody's mental health if they experience a physical work-related injury. It can lead to changes in physical functioning, social roles, and social interaction. And this can contribute to isolation, stigma, physical pain, and somebody's coping ability, all which can impact their positive mental health and potentially mental illness symptoms. The other reason why this is important is because we know that mental illness after a work-related injury reduces the probability of sustained return to work. And we know that when people leave the workforce or leave the labor force, this potentially is associated with decreasing mental health. And again, we want to have a mentally healthy workforce and population, and we want to make sure that people that experience a work-related injury are mentally healthy as well. So by understanding the complete mental health of injured workers, we can accomplish a couple of things. The first, we can identify those individuals who are languishing and might have mental illness symptoms, and then identify the best ways to help them. Alternatively, we can also identify injured workers that have flourishing mental health. So these are the individuals who are doing really well with their mental health, and identify who they are and why are they doing well. And lastly, by understanding the complete mental health of injured workers, we can further understand what role mental health plays in the return to work process. So given this, the study I'm going to present to you today had 3 objectives. The first objective was to uncover the number of underlying complete mental health groups. You'll hear me refer to these as latent classes in a moment, among individuals who experienced a disabling physical work-related injury or illness. Secondly, once we had these groups, we wanted to explore who they were, their sociodemographic health and return to work characteristics. Lastly, we wanted to quantify differences in the length and the cost of a worker's disability claim between the different mental health groups that we found. So to conduct this study, we used data from the Ontario Life After Workplace Injury Study, or ALOWI for short. The purpose of the study was to describe the long-term outcomes of workers who had a compensation claim for wage replacement benefits due to a physical injury or illness at work. Now, given that the study setting was in Ontario, it's important for the international viewers on the call today to talk about the Ontario Workplace Safety and Insurance Board. This is the insurance board that covers medical care services and wage replacement benefits for workers whose recovery from a work-related injury requires an absence from work. So how did we recruit our sample? Well, between June 2019 to March 2020, the WSIB identified just under 9,800 randomly selected WSIB claimants. And all of these claimants had an injury that occurred 18 months prior, between January to October 2018. Of these selected claimants, about 2,816 were reached by the WSIB and told about our study. Of these individuals, 1,674 consented to be contacted by interviewers, and then 1,132 ended up participating in a telephone interview and comprised the Olawi sample. Now, one thing that's important to note about our sampling is we oversampled claims that were of medium and longer duration. So we ended up with 3 different subgroups in our sample. We had individuals who had a short duration. These were those who had claims that were less than 3 months. We had a medium duration group, so this was 374 participants who had claims of 3 to 12 months, and then we had a long duration group, individuals who had claims of 12 to 18 months. So now that I've talked about what the data that we had and how we're going to use it, I'm now going to describe each of our objectives and what we found one by one. So our first objective was to uncover latent complete mental health classes. To do this, we used a technique called latent class analysis, and it's sometimes referred to latent profile analysis. Essentially, what this technique does is it takes a whole group of data and identifies subgroups within it that we can't necessarily identify beforehand. So to try and provide an example of this, if you're in the Toronto area, pretend that you're taking the GO train or the subway into Toronto at rush hour early in the morning. You have lots of different people on the train, and the train is packed with people. Every single person has some level of wealth, but we can't just go up to them and say, "How wealthy are you?" They likely won't answer, and we can't directly observe it. So we could ask everybody, what level of education do you have? Are you working? What's your salary? Do you own your home? And a variety of other questions. Based on the responses that we get, we likely could group people into groups based on how they respond. So in essence, that's what latent class analysis does. It identifies subgroups of individuals based on common characteristics, although not everybody will be exactly the same. So when I refer to latent classes as the presentation goes on, just think about these as subgroups of people. So to do the latent class analysis and complete our objective, our first step was to build a complete mental health model in statistical software. We then explored a variety of variations of this model where we differed the number of mental illness and positive mental health latent classes that we looked at. After having a variety of different model variations, to determine the most appropriate one, we used statistical criteria, as well as asked ourselves questions like, does this group actually exist in the real world, or is it just an artifact of our data? And then lastly, to complete the objective, for the most appropriate model, we described the number of latent classes that we found. We describe the distribution of the variables that we put into the model, and then qualitatively give our groups names. I'm now going to go through what variables we put into this model. So for the mental illness construct, we use 2 variables, where in our telephone interview, we asked individuals, have you ever been diagnosed with a mood disorder or an anxiety disorder by a healthcare professional? Our participants could answer, no. Yes, I have, and it occurred before my work-related injury, or yes, I have, it's occurred after my work-related injury. When it came to positive mental health, we had 4 groups of variables that we included in the model. The first was self-rated overall mental health, where we asked participants, in general, how would you rate your mental health? Something from excellent all the way down to poor. Our second group of variables were related to emotional well-being, and we included 3. So we asked participants over the past month, how often have you been happy, interested in life, and felt satisfied with life? Our third group of variables was related to psychological well-being, and again, we had 3 of them. We asked over the past month, how often have you felt calm and peaceful, had a lot of energy, or felt downhearted and depressed? And lastly, for social well-being, we asked 1 question about individuals' sense of belonging to their local community. So with all of these variables, this was the model that we built in our software. Anything in a circle is something that we can't directly observe, and any of the variables in a rectangle or in a box are one of those variables that I had just mentioned we included. So again, we were interested in identifying the number of latent mental illness classes, the number of latent positive mental health classes. We understood and incorporated that there's a correlation or a relationship between these two variables, and then set out to explore lots of model variations. So specifying different numbers of mental illness latent classes and positive mental health latent classes. So after doing this, we found that the most appropriate model had 4 latent mental illness classes and 3 latent positive mental health classes. So I'm now going to describe what these individuals looked like in terms of the variables that we included. So the table at the bottom of this slide shows how participants responded to the mood disorder and anxiety disorder diagnosis variable. And in the row, we have our different latent classes or our different mental illness groups that we found. So our first class was 8% of the sample, and we called these individuals the highest prevalence of mental illness post or after work-related injury. And this is because 52% reported that they had a mood disorder diagnosis occur after their work-related injury, and this was 45% for an anxiety disorder diagnosis. Our second group was 10% of the sample, and we called these individuals the highest prevalence of mental illness before the work-related injury group. And this is because 52% reported I had a work-related injury. I had a mood disorder diagnosis occur prior or before my work-related injury, and 37% reported an anxiety disorder before their work-related injury. Now, our last 2 classes, we call the low prevalence of mental illness and the lowest prevalence of mental illness, because as we can see, over 90% of these individuals reported, I don't have a mood disorder diagnosis, and I don't have an anxiety disorder diagnosis. And we can see that class 4 has a slightly greater proportion of individuals in this group, so that's why they get the lowest title. Now, moving on to the positive mental health latent classes, the table on the right of our slide shows how our different classes responded to some of our variables in the model. So our first class was 14% of the sample, and we called these individuals the languishing positive mental health class. And we can see that by how they responded. 92% responded that they perceived their mental health to be poor or fair. 27% reported that they never felt happy in the past month. 33% reported that they never felt calm or peaceful. And 67% said they had a very or somewhat weak sense of belonging to their local community. Our second group, we called the moderate positive mental health group. They were about 25% of the sample, and we can see that they scored a little higher or a little more positively on our measures. So in this case, just under 50% responded that their perceived mental health was poor or fair. They scored quite well on the emotional well-being variables, but in the psychological well-being variables, we see between 8 to 15% responding quite negatively or languishing on the questions, and 35% responded that their sense of belonging was very or somewhat weak. Now, our final class, and the largest one at 61%, was the flourishing positive mental health class. And we can see by the way that they responded, these proportions are very low, indicating that they responded quite flourishing on our perceived mental health, emotional well-being, psychological well-being, and social well-being variables. The next question was, how does somebody's positive mental health and mental illness group relate to each other? So this graph on our x-axis shows our 4 mental illness groups, and the different color bars represent the languishing positive mental health group, so that's the purple bar. Moderate positive mental health is the blue bar, and the yellow orangish bars are the flourishing positive mental health within each group. So what we can see here is that for our higher mental illness prevalence classes, class 1 and 2, we see tall purple and blue bars, suggesting that the majority of participants in these classes fell into the languishing or moderate mental health class as well. Now, for our lower prevalence mental illness groups, we see tall yellow bars with over 70% of these participants falling into the flourishing positive mental health group. So now that we uncovered our groups, understood a little bit about their complete mental health variables, our next question was to identify sociodemographic health and return to work characteristics of these profiles. So in our telephone questionnaire that we provided to participants, we asked about a variety of sociodemographic, health-related variables, and return to work-related variables. For this objective to complete it, we explored the distribution of these variables between our 4 mental illness classes and identified trends and patterns, and then repeated the same among the positive mental health latent classes. So starting with the latent mental illness groups, we found that compared to the low prevalence mental illness groups, so those were class 3 and 4, more participants in the higher mental illness groups, so both those individuals who had a diagnosis either before or after the work-related injury, identified as a woman, had single marital status, they had not yet returned to work at 18 months after their work-related injury, they had longer claim durations, financial concerns, still were receiving healthcare for injury, had other health conditions, reported less sleep per night, higher pain levels, in using oxycodone or other opioid products in their treatment for their injury. Now, to talk a little bit about what the gradient between these classes looked like, I'm going to highlight the financial concern variable. So we asked participants, during your claim, did you have financial concerns? Those in our high mental illness prevalence before the work-related injury group, 81% said yes. This was 67% among the high mental illness group after the work-related injury, 48% in the low prevalence group, and 44% in the lowest prevalence group. Now, moving on to differences between our 3 positive mental health groups. Compared to the flourishing group, we found that more participants in the moderate or languishing groups reported very similar trends. So single marital status, having a variety of other health conditions, they had not yet returned to work, longer claim duration, again, financial concerns. They were still receiving healthcare for their injury, reported less sleep, higher pain levels, using an oxycodone or opioid product as part of their treatment, and also a slightly higher proportion reported that they used cannabis in the past year. So again, to look at what the trends between these groups look like, I'm going to highlight the still receiving healthcare for injury variable. So again, we asked participants 18 months after their work-related injury, are you still receiving healthcare for it? Just under 50% of the languishing group said yes. This was 37% for the moderate group and 25% for the flourishing group. I mentioned that for both our mental illness classes and our positive mental health classes, a higher proportion had not returned to work. And I just want to highlight what that looked like. So we asked participants, again, in the telephone interview 18 months after their injury, what's your current work status? We found that between 35 to 39 of our high mental illness prevalence latent classes said, I'm not back at work yet, compared to 20% in our lower prevalence groups. When it came to positive mental health, we saw that 43% in the languishing positive mental health group responded, I haven't returned to work yet. So I also highlight this as a little bit of a teaser leading into our final objective, to look at the length and cost of a disability claim among our different complete mental health profiles. So for participants who consented, we ascertained some of their claim-related information from WSIB administrative records. For this objective, we looked at 2 variables, the total number of loss of earning benefit days and the total amount of loss of earning benefit dollars. And we conducted an ANOVA test to test differences, again, between the 4 mental illness classes and then between the 3 positive mental health classes. So this table shows the distribution for our loss of earning days and our loss of earning claim amount variables. I highlight the medians and interquartile ranges for our 4 mental illness groups and our 3 positive mental health groups. So there's a lot of numbers in this table, I know. So I'm going to walk us through one group at a time. So when we look at our 4 latent mental illness classes, this is the picture that emerged. For our loss of earning benefit days, we found a statistically significant difference. So we found that the lowest prevalence of mental illness group had a median loss of earning benefit duration of 32 days. This increased to 46 days for the highest prevalence of mental illness post-work related injury and our low prevalence of mental illness group. And then the highest median loss of earning day duration was 57 days. And this was for the highest prevalence of mental illness before the work-related injury group. When it came to the loss of earning claim amount, we did not find any statistically significant difference between these four groups, but their median claim amounts ranged between $3,500 to $4,500. Now, when looking at our positive mental health group, we saw a pretty clear trend emerge. For both loss of earning days and loss of earning claim amount, we found statistically significant differences between the average benefit duration and claim amount. So the trend that we saw is as positive mental health decreased, so went from flourishing to languishing, the duration and cost of the claim increased. So for example, in this table, you can see that for the flourishing positive mental health group, their median loss of earning duration was 32 days, and this increased to 59 days for the languishing group. In terms of the cost of their loss of earning benefit claim, this was $3,600 among the flourishing group, again increasing to $5,100 in the languishing group. I've thrown a lot of information at you over the past 15-20 minutes. I'm now going to summarize it and discuss some next steps and where to go from here. So let's summarize the findings. For our first objective, again, at the beginning of the presentation, I had said one of the key takeaways is the mental health of injured workers isn't a one-size-fits-all. And that's what our first objective showed us. It showed 4 distinct mental illness profiles, 3 distinct positive mental health profiles, and it also showed us that these groups were pretty correlated with each other, which if you had higher mental illness prevalence, if you belong to one of those groups, you also likely belong to the moderate or languishing positive mental health group. This is important because, to our knowledge, this is the first study that's looked at mental health of injured workers directly in this way using this specific framework. For our second objective, we found that there were differences in terms of demographic, health, and return to work factors between these different groups. And we found that those participants who were in one of the higher mental illness groups or the languishing mental health group reported financial concerns, had not yet returned to work. Many participants reported the presence of other chronic conditions and that they were still receiving healthcare for their injury 18 months after the injury occurred. So again, this is leading us to understand that it's not just mental health that these individuals are working with, and it's not just their physical injury. There's a lot of other factors that might be contributing to stress, which can impact, again, mental illness symptoms and positive mental health. And from our final objective, we saw that the duration of loss of earning claims were longer among the higher prevalence mental illness groups, and the duration and cost of loss of earning claims were higher among the languishing and moderate positive mental health groups when compared to the flourishing group. So this study is imperfect, and I'm going to talk about some of our limitations and how we can improve upon them in future research when continuing to explore the positive and complete mental health of injured workers. So first, our study used a cross-sectional cohort, so we can only describe what was happening at that one point in time. So moving forward, it'd be great to have longitudinal information on the complete mental health of injured workers over the return to work period. So not just 18 months, but early in the injury process and return to work process, all the way up until they return to work. Secondly, I want to talk about our sample size. So I had mentioned our sample was about 1,100 individuals, which sounds really big and great. But as you saw, we found 4 mental illness groups and 3 positive mental health groups. So in total, if we combine both of those, so everybody has a mental illness and positive mental health profile, that leads to 12 groups. And looking at it that way really reduced our sample size. And we want to be able to talk about that nuance. So further research should try and use larger samples so we can look at these nuanced complete mental health profiles of both mental illness and positive mental health constructs. And lastly, again, this study is a starting point, and it's the starting point of describing the complete mental health of injured workers. So we know that the model that we built is just an initial model. There are a lot of other variables related to mental health, like family history, substance use, and potentially post-traumatic stress disorder symptoms that would be great to include in the model. So taking this the next step in future research, let's increase the robustness of this model to really identify what mental health is looking like. So I've summarized what we found. I've talked about what we should do next. I'm now going to leave you with 3 concluding remarks. First, our study findings support that we should acknowledge the importance of complete mental health of injured workers. We need to further explore how positive mental health impacts injured workers in the return to work process. And finally, identify ways to support the complete mental health of injured workers. So with that, thank you very much for listening to me today. I'm really excited to answer your questions and continue a conversation.
Thanks very much, Kathleen. Thank you for making sense of what are really complicated, complex data and scenarios. Very much appreciated. We have a number of questions, so I will try to get through as many as I can. If you have a question or a comment, please leave it in the question and answer box. And if we don't get to it today, please do reach out to Kathleen, who will be happy to answer your questions offline. Maybe I'll just start with a couple of clarification questions, some quick clarifications, and then move into some of the comments and more complex kinds of issues that you might want to address. So the first question, will you be sending the outcome of this research to the WSIB and other worker compensation boards in Canada?
Yes. So again, we have published the study online. It is available to everybody. And given that the WSIB was the funder of this project, they are aware of our findings.
And we also publish things for those of you interested on the IWH website. And so the slides are there. All our presentations are available there. So thank you. Can you clarify, Kathleen, what the difference is between mental health disorders and illnesses? You used, mental health disorders, illnesses. Can you just remind us sort of what the differences are there? Are you using some of these as synonyms?
Yes. Again, it kind of relates to the point that we use a lot of terms and what do they mean? In this presentation, I was using that as synonyms. So a mental illness, a mental health condition, or a mental disorder, we can group those as one thing.
And do you know, in terms of long-term disability claims, what the term is that they use? Like, is it a mental health disorder, mental illness? And you may not know.
Unfortunately, I don't know that, but if anybody on our call in our audience today does, please feel free to email me because I want to be using the correct terms.
Okay, thank you. Another question, sort of clarification question. One of the listeners noted that they thought your numbers for workplace injuries in Canada was low. And so a couple of questions. Are you talking about those where claims have been accepted or by a worker compensation board, or are these a number of injuries? This is on one of your earlier slides.
Yeah, so that statistic, the just under 40,000 number, came from a report published on the Government of Canada website. I believe it was the EDCS, the employment, I forget what the acronym is, I'm sorry, but it is a report that they publish every year on work-related injuries in Canada. So when the slides are posted, I have hyperlinked the link so that can go, our listeners can find it.
Okay. And someone has sent you a different report, a BC report. So you'll have that as well. A question for you. This is now moving into sort of more of the speculation and maybe new research. Someone has asked about whether or not if you had included workers whose claims were refused or who have been in the system a longer time, like more than 18 months, do you think you'd see a difference? And they note in their experience with injured workers that often there's quite a bit of anger, fairly serious anger that comes up in ways beyond their claim. Do you know about any research like that? Is it possible to look at claims that have been refused in data?
So that's a really important question. And I want to reemphasize that this is just our first study looking at this. So unfortunately, we didn't have information on people's claims that have been refused. But in speaking with injured workers groups, we know that the return to work process can be really challenging, and especially when people get into those scenarios. And yes, there can be anger, and that can impact people's positive mental health and potentially exacerbate mental illness or mental health conditions if they're there. So if I'm going to speculate, again, this is outside of our data, those individuals likely would fall in our higher prevalence of mental illness groups and our languishing or moderate positive mental health groups, but definitely a great place for future research and to keep discussing.
Okay, thank you. And just related to that, do you have any data on the reasons why people did not return who were still off after 18 months? Noting that, the longer someone's off, it seems harder to get them to be able to return. Do you have data on that?
So we do have data on that. We haven't looked at that specifically in this study, but we do have another study that's not so related to mental health, but describes the reasons why people didn't return back to their at-work injury employer. So that should be on our institute website and is a great place for readers to find that out.
Okay, thank you. Another question about who people are dealing with WSIB versus dealing with private insurance companies or other groups. First of all, do you have data on that? And if you do, is there a sense that working with some groups, like dealing with a private insurer, is easier, harder versus the WSIB? Do we know?
So in terms of the data that we used for this study, we only have information about people dealing with the WSIB. Again, in Canada and in Ontario, the WSIB is the disability insurance organization that provides benefits for workers who had a work-related injury and need to take time off of work. But talking about dealing with private insurers is an interesting and important question because we know that our system here in Ontario isn't the same everywhere else. So unfortunately, we can't speak exactly to that, but is a great place again for future research.
Okay. You mentioned asking injured workers about marijuana use. Did you also ask about alcohol use? That seems to be still more common than marijuana.
Yeah, we did ask about alcohol use as well. We didn't discern clear patterns from our data. So in essence, that's suggesting that alcohol use is generally similar among our groups.
Okay, thank you. A number of questions, and again, maybe this is for future research, but really talking about how much of the mental health issue or languishing is about the nature of the injury, how much might be, you mentioned, there's sometimes some of this is there already, how much of this might be even related to the treatment they're getting or who's providing the treatment. Are there studies that tease apart some of those issues, and have you tried to, or do you have the opportunity to do that with some of these kinds of data?
So in terms of the data that we do have information on people's return to work experience. So for example, how they were dealing with their case manager and how they were dealing with their employer and returning to work. So it's definitely something that we could look at with this data. But again, with this study, we really just wanted to put the baseline level of what is mental health looking like, and let's uncover different groups. In terms of teasing apart where mental health issues are coming from, whether it's being isolated, so not at work and with the people that you typically work with and see every day, the process of navigating the return to work, whether it's with your case manager or your employer, or the physical injury itself, it likely is coming from a variety of places and a variety of those places. But in terms of saying the proportion that's coming from this one avenue would be pretty hard to say.
Okay, thank you. Sorry, I'm just firing questions off at you. We have a lot of questions. And again, thank you for this. And all of the questions are sent to Kathleen at the end of the presentation, even if we aren't able to answer all of them today. We have a listener who's asking about workers who don't speak or don't write English, and whether they're included in the study, and if if they are provided with interpreters or opportunities to have some help to get them through this, either these questions or this process.
Yeah, so unfortunately in our study, it was restricted to those who spoke English. So if somebody did not speak English or English wasn't their first language and they didn't feel comfortable speaking English, they weren't included in our study. So definitely that's an important group to deal with. And outside of kind of the mental health and work and injured work literature and the mental health epidemiology literature, we know that language barriers and things potentially related to immigration status can really impact people's mental health, again, because of the challenge of navigating a system that isn't necessarily in their first language or they don't feel comfortable with. So this is a kind of mental health wide system issue and definitely would trickle down into the injured worker experience as well. So again, a great place to potentially look at.
Do you have a sense of how many people were excluded from this study, or what percentage of people were excluded based on English language skills?
I don't have that at the top of my head, unfortunately, but if somebody wants to send me an email, I'm happy to find out that information.
Okay, thank you. So lots of positive comments too about the presentation and how helpful it was, how interesting. So I just want to note that. We have a question asking whether you can comment on control groups. So looking at your data and comparing it to people with non-occupational mental health illness, for example, or other types of long-term disability claims.
So when we set out to do this study, again, it was we want to identify what people's mental health is looking like. And in the work and kind of occupational literature, unfortunately, there isn't too much of that. We only found one other study that used a similar technique. It wasn't in an injured workers population. Their results were similar to what we found, again, slightly different. And it also happened in a different jurisdiction. So it wasn't in Canada. And in terms of what we know about kind of positive mental health in the workforce in Canada, a study by IWH that was conducted a few years ago found that 77% met the criteria for flourishing mental health, although that might be changing in the adult population as we have gone through COVID-19 and some other macroeconomic challenges. But to summarize, we're kind of at the beginning of this in the kind of injured workers research and the work and health research. So again, let's keep pushing it forward so we can have those comparisons and understand what the differences are.
Okay. Someone is asking, do you think your study is making a case for employers to measure positive mental health of workers more regularly, potentially even to intervene to improve mental health before an injury occurs?
So that's getting to the concept of positive mental health prevention, right? Positive mental health maintenance, keeping people at a flourishing level and trying to keep them there so it doesn't go down. And that's a phenomenal idea to do. In terms of measuring it and measuring it regularly, it doesn't necessarily have to be a survey that's given out to everybody's employer, but it could be something as simple as a one-on-one check-in with your manager saying, how are you doing? Are you feeling happy these days? And it's definitely a great place to start. And that's probably where I would start before thinking about what interventions to put in place.
Okay, so related to that, another question, and you may have given the first point, how can workplace health and safety leaders use this research in their day-to-day? And so the checking in is something that you've just noted. Is there anything else that you would suggest for them?
So again, acknowledge that mental health is complex and there's a lot of aspects to it. Second, we can start small. So again, the one-on-one, the really kind of knowing your colleagues and making your work environment feel like a community and a social place to be and a place where people want to participate and contribute to. Third is, again, emphasize that mental health is having an impact. Again, we've shown it very descriptively and it's not causal and we can't claim things with a causality stake, but it is impacting injured workers and their return to work process. So thinking about ways that we could improve and help people's mental health or keep it at a high level if it's already there is really important.
Okay. Did you see any differences in mental health related to various occupations or sectors in the study?
Yeah, so in our study, we didn't actually find differences between occupations. Sorry, I should say we didn't find differences within industry. That was the variable that we had for it. In terms of the allowee cohort itself, many of the participants were in the healthcare sector, as well as the construction, mining, and in forestry sectors as well.
Okay, thank you. Lots of interest in these data showing that people, a number of them had mental health challenges prior to an injury, and wondering, are there ways then to, you talked about checking in, which is very nice, but are there ways to kind of, an employer should maybe try to deal with that? Does it make it really hard to tease apart what's going on if that's the situation? Any comments that you have?
The first thing I want to say is mental health is messy. It's complex. And when we think about the working population, you're 18 by the time you can potentially enter the workforce full time. So you have 18 years of stuff that might already have been impacting your mental health. So to think when we have adults that it's going to be a clear-cut picture, that's likely not what we're going to see. In terms of what employers should do, the second thing I want to mention is think about what you can do in your psychosocial work environment. And we have some great resources at IWH and great plain language summaries that can help with that. Or not help, but provide some suggestions.
Okay. Someone said that they thought one of the most interesting considerations of the complete mental health model was the idea that people who are struggling with a mental illness can still flourish. And were there any factors that you think you found or that you think could be included in studies to distinguish workers who have an illness from those who are flourishing with that illness from those who are languishing?
So in kind of the positive mental health literature, so outside of the injured worker space, we do see that individuals experiencing high level of mental illness symptoms and languishing, they do go hand in hand. And again, we kind of saw that in this study where our higher prevalence mental illness groups, the vast majority of those individuals were falling into the moderate or languishing positive mental health groups as well. So in terms of thinking about how to tease that apart and things to do. Sorry, I just lost my train of thought. Thinking about things that can target potentially both positive mental health and mental illness symptoms would be a great place to start. And I think based on our study, one finding that I found quite striking was related to people's social well-being. A lot of individuals in the languishing and moderate mental health groups, and we also saw this when we looked at it by mental illness class as well, said, I don't really have a strong connection to my community. So thinking about increasing social support, again, as simple as a way of making a call to somebody, or if you're a colleague of somebody who had a work-related injury, just calling to check in on them would, again, be simple place to start before thinking about where to place resources.
Right. And I'm glad you mentioned that this was a striking finding for you, because we have another question that asks, what were the most surprising findings for you in this research? You've done a fair bit of it.
So as somebody who's been researching in this area for many years now, the things that I found most surprising were the number of classes that we ended up with, both for mental illness and positive mental health. I use these techniques a lot in my research, and it's always the funnest part to see what's going to happen. So I would say that, and I again would say the finding about social well-being, about especially in the languishing group, how many people didn't have a great sense of belonging to their community.
Okay, thank you. Lots of ideas for future studies coming through, so thank you, everyone. So interest, for example, in differentiating between types of mental health conditions more. Depression, PTSD, looking also at differentiating between types of injuries, or sectors or number of injuries. Can you comment on how much of that would be possible for you and your team to take a look at if you had the funding?
If we had the funding, sky's the limit. Again, it's a really important area of research in understanding differences in complete mental health based on what type of injury do you have? And kind of not to say we can talk exactly like if you broke your arm versus if you got a had to have some sort of surgery. We can't unfortunately look at that in our data, but one clue is kind of related to the length of somebody's claim. So we had those three groups: the short duration claim group, the medium, and the long-term relation claim group, because less severe injuries likely would be able to get back to work a little more quickly than a more severe injury.
All right, thank you. Um, you looked at claims based on duration. Would you say that duration is a good proxy for severity of the injury, or is there other data that we could use to look at severity?
That's a great question. I'm going to think about that for a second before I answer it. So, based on our Allawi cohort, and again, this isn't the only study that we've published about. We've published about pain, we've published about cannabis use, we've published about permanent separation from work. In our data, and again, we haven't presented it here, but typically the more severe injuries, for example, like an amputation, is associated with a longer return to work and longer claim duration. It might not always track, but in our case and in our data, we're seeing that it's tracking pretty well.
Okay. You've had to look at the literature a fair bit. I know you're not familiar necessarily with all the policies in different countries, but we had a comment and a question. Someone who has had some experience with Canada, the US, and Australia, and who feels that the findings could really quite reasonably be applied in other jurisdictions. And do you have any comments about that? Any thoughts about what would make things similar, different in other countries?
So that's a that's a great and complicated question, but I'm happy to hear that one of our listeners thinks that the findings are quite broad and could be applied broadly. It really depends on different systems. They might work in slightly different ways. Again, here in Ontario, we have a single insurer. If you're in a jurisdiction with multiple insurers, it might get a little more complicated. So again, going back to the last question, if you had extra funding, what would you do? Looking at how these findings could be applied to other jurisdictions would be something I would love to research.
Okay, great. Were there any common factors in the flourishing groups that could have contributed to their positive experiences in return to work?
Yeah, so I think if I had to pull out a couple of the findings that I presented today for our mental illness group, and actually for both of them, they reported that they were sleeping more and they had less pain interference. And we know that experiencing pain can be really associated with somebody's mental health and mental well-being. And I don't know about people on this call, but for me, when I don't sleep, the next day I'm feeling a little grumpy. And if you're dealing with a lack of sleep based on a work-related injury and you're in pain, that's not a great combination. So that's probably the findings I would tease apart. So again, relating back to the flourishing group, they weren't necessarily experiencing those issues. So it might be a little easier for them to recover and return to work and keep their mental health up.
Okay, thank you. I'm just looking at the clock, and I want to thank everyone who has attended. We have a really nice large group, as you can tell, lot very interested with all the questions and the comments that have been coming in. I'm sorry that I didn't get a chance to go through everybody's question and comment. As I mentioned, please do contact Kathleen directly. And Kathleen, I want to really thank you for your presentation today. It was really interesting. Got a lot of people thinking about mental health and injury. So thank you for that. I want to invite all of you to come back in a month if you can and join us for a presentation that's actually a bit related to today's topic. On February 25th, Dr. Bashak Yanard and Cameron Mustard are going to present on employer perspectives on supporting public safety personnel's return to work after post-traumatic stress injuries. And this is more qualitative research, so a different kind of lens on the issue. But thank you all again for joining us, and thank you, Kathleen. I hope you all have a wonderful day. Take care.